Okay, now we're gonna discuss the rheumatology first part. Okay, so if you are a 23-year-old female who comes to the clinic due to leg pain and chest pain and joint pain, your analysis shows microscopy of 10 red blood cells per high power field. Your protein is 2 plus. What's best next step? Best next step we do anti-nuclear antibody, because this could be SLE. So the SLE, they have gradual symptoms of onset, malar discoid rash, joint renal, serosal, and neurologic involvement. Lab, you have anemia, leukopenia, thrombocytopenia, positive ANA and anti-double-stranded DNA, and anti-SMID. You have low complement and increased immune complexes. That's the thing. Okay, so if you are a 60-year-old male who being awakened by severe pain on your right great toe, so what could be causing this issue? It could be myeloproliferative disorders. So the causes of gout, there is increased some of the stuff that increases urate production due to primary gout, myeloproliferative disorder, tumor lysis syndrome, hypoxanthine guanine phosphoribosyltransferase transferase deficiency, and decreased urate clearance. For example, chronic kidney disease, thiazide, loop diuretics. Those are causes of gout. Now, if you are a 25-year-old male who presents with a right shoulder pain and tenderness at the acromioclavicular joint, palpation over the heel, iliac crest, tibia tuberosity, elicit tenderness. What else could I find? I find limited spine mobility, because this is most likely ankylosing spondylitis. The inflammatory back pain cause insidious onset at age less than 40, symptoms more than 3 months, relieved with exercise but not rest. Nocturnal pain, they have nocturnal pain. On exam, you find arthritis, sacroiliitis, reduced chest expansion, spinal mobility, enthesitis, tenderness at tendon insertion site, dactylitis, swelling of fingers and toes, uveitis. Those are complication. You have osteoporosis, vertebral fractures, aortic regurg, and cauda equina. On labs, you have elevated ESR, C-reactive protein, HLA-B27 association. Imaging, you do X-ray of the sacroiliac joint and MRI of the sacroiliac joint too. Now, if you are a 72-year-old male who was admitted to the hospital for an elective inguinal hernia repair, okay, on physical exam, I found redness and swelling over the right knee and limited motion due to pain. So I do synovial fluid and I found white BC 30,000. Wow, neutrophil 90%, and polarized microscopy few rhomboid shaped crystals. So what associated with this current condition is most likely meniscal calcification. Was that this pseudo-gout, acute calcium pyrophosphate crystal arthritis symptoms? They have acute mono or oligo arthritis. Peripheral joint, knee most common. How to diagnose it? Inflammatory effusion, 15,000 to 30K cells per mm square. And you have CPPD crystal, rhomboid shape, positive, birefringent. Chondrocalcinosis on imaging. How do you treat it? Intra-articular glucocorticoid, non-steroidal anti-inflammatory drugs, and colchicine. That's what you manage. Okay, now, if you are a 68-year-old woman with a proximal and distal interphalangeal joint pain and stiffness that's been getting worse, what could be causing this? This is most likely osteoarthritis, because it's a proximal and distal interphalangeal. Those are the rheumatoid arthritis is the endometacarpal phalangeal joint. And the osteoarthritis, they have both near deformity. That's a difference. Okay, so if you are a 65-year-old male with left thigh pain, on alkaline phosphatase is increased, and bone scintigraphy shows increased uptake. So what else should I expect with you? Most likely hearing loss. This is a Paget disease of the bone, causes headache, hearing loss, spinal stenosis, radiculopathy, long bone bowing, fracture, arthritis, joint cell tumor, osteosarcoma. Pathogenesis is osteoclast dysfunction and increased bone turnover. Lab testing shows increased alkaline phosphatase, elevated bone turnover markers, BNP, urine hydroxyproline, calcium and phosphate usually normal. Imaging, X-ray, you have osteolytic, mixed lytic and sclerotic lesion. Bone scan shows focal increased uptake. Treatment with bisphosphonate. Now, if you are a 70-year-old male present with pain and stiffness in the neck, shoulders, and hips for the last 3 months, and you lost a couple of pounds, and when I examine you, I found no overt synovitis, but your ESR is 85%. So this is most likely polymyalgia rheumatica. So you treat it. So how do you treat it? With response, if it responds to steroid, that's management. Lab, you have ESR more than 40, sometimes more than 100, and you have normocytic anemia. Possibly 20% have normal studies. They have neck or torso, shoulder, proximal arm, proximal thigh, okay, and they have constitutional symptoms. That's different. Now, if you are a 62-year-old Caucasian female present with difficulty swallowing for solid foods, and you need to take sips of water during every meal to help with the swallowing. On exam, I have found prominent dental caries and bilateral firm submandibular swelling on the neck. What could be? This is antibody to RO and SSA. Now, if you are a 24-year-old woman who present with a low back pain that worsens in the morning, and you have a stiffness, you have more that you have pain worse in the morning and gets better as the day goes by. So what could be causing this? Most likely ankylosing spondylitis. So what do you expect? Else do you expect? You expect anterior uveitis associated with ankylosing spondylitis. Okay. So if you're a 30-year-old white male present with a low back pain, stiffness, bloody diarrhea, and erythematous nodule on the shins, Bianca is positive. Lab shows anemia and thrombocytosis, and you have a bloody diarrhea. So what could be causing that? Most likely inflammatory bowel disease. There's pains called inflammatory arthritis. Now, if you have a hypothenar atrophy or thenar atrophy, if you have thenar atrophy, that's an medial nerve damage, carpal tunnel syndrome. If it's a hypothenar, that's an ulnar nerve. So carpal tunnel syndrome is associated with obesity, pregnancy, diabetes, hypothyroid, and rheumatoid arthritis. Clinical presentation, you have pain, paresthesia on the medial side, on the first 3.5 digit, positive Palin and Tennel test. Severe disease, you have weakness, thumb abduction and opposition, atrophy of thenar eminence. Confirmatory test, nerve conduction study. Treatment, you do wrist supplanting, steroid injection, surgery for severe or refractory symptoms. Now, if you are a 66-year-old asymptomatic woman and you just had a hysterectomy and removal of the cervix, and now what should I do? DEXA scan, as long as you're 66 years old. Above 65, you got to do a DEXA scan. So what are the osteoporosis risk factors? Advanced age, 65. Medical history of fracture with minimal trauma, fragility fracture. Low body weight. Family history of hip fracture. Current smoking, excess alcohol intake, medication like steroid, anticonvulsant, secondary causes of osteoporosis, premature menopause, hypogonadism, malabsorption, celiac disease, inflammatory disorders like inflammatory bowel disease, rheumatoid arthritis. Those are types of things. and hyperthyroidism, hyperparathyroidism, Cushing syndrome, vitamin D deficiency, chronic liver or renal disease. So those are the risk factors. Now, if you are a 49-year-old African American female present with exertional dyspnea and heartburn, your skin is thickened and discolored over the fingertips and the interphalangeal joints. So what's causing this? What's the next step? We do anti-topoisomerase 1 antibodies, most likely systemic sclerosis. Okay, so if you're a 31-year-old Caucasian male who present with urethral discharge and mouth ulcers, so how can I treat that? That's reactive otitis. Just give you an steroid anti-inflammatory drug. Now, if you are a 68-year-old woman with severe pain on your fingers, okay, and you have tophaceous gout on your fingers, that's most likely gout can happen. The gout picture. Now, if you are a 34-year-old woman who have facial rash, joint pain, oral ulcers, and using hydroxychloroquine, so what should you evaluate before starting hydroxychloroquine? So you do eye examination because it causes retinopathy. Sulfasalazine causes hepatotoxicity, so hydroxychloroquine, TNF, and interleukin-1 inhibitor cause retinopathy. Sulfasalazine, same mechanism, TNF and interleukin-1 inhibitor, cause hepatotoxicity, stomatitis, and hemolytic anemia. Leflunomide, it's a pyrimidine synthesis inhibitor, cause hepatotoxicity and cytopenia. Methotrexate, purine antimetabolite, cause hepatotoxicity, stomatitis, cytopenia. TNF inhibitor like adalimumab, sitolizumab, etanercept, golimumab, infliximab. Adverse effect cause infection, demyelination, CHF, and malignancy. Now, if you have a Paget disease by alkaline phosphatase is 700, and you felt that you had it, your head is tight and you can't put the thing on your skull, and you're a construction worker, what should I do? Give you Aldronate. That's treatment for Paget disease. So if you are a 55-year-old woman with 1 week of pain in multiple joints and pain in the metacarpophalangeal joint and proximal interphalangeal joint, when in examination everything is fine, you just have pain. So what is that? This is viral arthritis. It's no big deal. Not an issue. Now, if you are a 58-year-old woman, when I examine you, I found mild effusion, tenderness, and decreased range of motion of the left knee. And there's a fluctuant swelling along the posterior aspect of the knee. White BC is 1000, gram stain nothing, crystal is absent. Okay, so X-ray reveal what? Most likely reveal narrowing of joint space and osteophytes. So there are the joint characteristics. If the white BC is 200 to 2000, that's non-inflammatory osteoarthritis. Normal is less than 200. And inflammatory, like crystal or rheumatoid arthritis, it's from 2000 to 100,000. Septic arthritis from 50,000 to 150,000. Polymorphonuclear leukocyte, 25% in non-inflammatory, 50% in inflammatory, and 80 to 90% in septic. The appearance, non-inflammatory and normal appear clear, but the inflammatory translucent or opaque, but the septic present opaque. Now, if you are a 52-year-old male present with pain and swelling over the right knee, on physical exam, I found moderate-sized effusion of the right knee with erythema and warmth. Okay, when I found the arthrosynthesis, I found negative birefringin. So what's causing that? This is most likely monosodium urate crystal deposition. That's what's causing this issue. Now, if you are a 35-year-old woman or present with an aching pain and stiffness on your entire body. On examination, there is tenderness to gentle palpation over the muscles of the neck, shoulder, and back. So what's the best initial therapy to improve the symptoms? Most likely exercise program with aerobic conditioning. Now, if you are a 35-year-old male who presents with a severe back pain when you were carrying heavy pack, the pain radiates to the posterior surface of the right thigh. What's the management for that? There's no need for MRI, X-ray, or anything like that. Just early mobilization and administer the anti-inflammatory drug. But if the pain persists more than 4 to 6 weeks, then you do MRI or other stuff. So if you are a 45-year-old woman with a fever and mild swelling on the joint of the hand and wrist, right knee is red and more swollen than the previous exam. Active and passive range of motion of the right knee are limited due to pain. So how do you treat this? Give them antibiotic. This is most likely septic arthritis. So septic arthritis, you have abnormal joint like osteoarthritis, rheumatoid arthritis, prosthetic joint, gout, and increased risk factor. Age more than 80, increased risk factor. Other risk factors: diabetes, IV drug abuser, alcoholism, and intra-articular steroid injection. How does that present? Acute monoarthritis, hot, swollen, decreased range of motion, fever, elevated ESR and seroactive protein. Diagnosis by blood culture, synovial fluid analysis. You have leukocyte more than 50,000, gram stain and culture. Initial treatment: if it's a gram-positive, you give the gram-positive cocci. You cover that by vancomycin, and you cover the gram-negative rod by third-generation cephalosporin. Okay, but if you have negative microscopy, you give vancomycin plus ceftriaxone if immunocompromised. Now, if you are a 28-year-old woman who presents with a left joint pain, okay, and left ankle pain, so migratory arthritis, fever, and white BC count in synovial 50,000, and you're sexually active, having multiple partners, that's most likely gonococcal septic arthritis. So how does that present, disseminated gonococcal infection? It presents with a purulent arthritis without skin symptoms, skin lesions, or it can have triad of tenosynovitis, wrist, ankles, fingers, and knees, plus dermatitis, pustules, macules, papules, bullae, and plus migratory asymmetric polyarthritis without purulent arthritis. Okay, so it's migratory. That's interesting. The right wrist and left ankle. So this is combination. When you see that, that's most likely gonorrhea, gonococcal. How do you diagnose it? You do blood culture, 2 sets, but maybe negative. You do synovial fluid analysis, may show up to 50,000. Urethral, cervical, pharyngeal, rectal culture, you can do that. That's important. And you recommend HIV and syphilis screen. And if it's a recurrent disseminated gonorrheal infection, then you check the terminal complement activity, because that can predispose to gonorrhea infection. Treatment: you give IV ceftriaxone for 7 to 14 days, and then switch to PO cefoxime when clinically improved. You do joint drainage for purulent arthritis, arthroscopy, that's an important one. And then empiric azithromycin single 1 gram dose, or doxycycline for 7 days for concomitant chlamydial infection. And you obviously treat the sexual partner, that's a very important one. And that's the end of the first part of rheumatology.